I think we'll begin. So like I said, we're here tonight for insights and strategies to manage challenging patient encounters. I will begin by doing acknowledgement of country. I would like to acknowledge the traditional custodians of the lands on which our work takes place, the Wurundjeri people, the Burrawong people, and the Wathaurong people, and pay my respects to elders past, present, and emerging, as well as pay my respects to our Aboriginal and Torres Strait Islander people in the meeting with us tonight. Just a little bit of housekeeping to begin with. So everyone has entered the meeting on mute. We ask that you do put any questions you have in the Q&A box. Please, let's make it an interactive session. Put your questions in. Questions will come through anonymously as this session is recorded. So for your privacy, send the questions through. I'll ask the questions. As we go along, I'll try and to get the questions in as Ruth is speaking. So please try to send anything through that comes to mind. If you're thinking it, somebody else will be as well. Also, make sure you have joined with your name. Some participants might come through as, Bob's iPhone. So please just check what name you've come in as. There is some instructions. All you need to do is go to the participants button. That should be at the bottom or at the top of your screen, depending what version you're on. Hover over click the participants button, find your name, hover over your name, like it says here, go more, and then rename, and then you pop in your name in there. So just as it says on the screen. Also, the agenda will take roughly we should be done by 8 o'clock. So presentation 1 hour, Q&A is 15 minutes. We will send through an evaluation survey through the chat, and we should wrap up. Wrap up and conclusion should take about 5 minutes. But we're hoping we'll be done by about 8 o'clock. But please send your questions through so we can actually, make it as interactive as possible and get lots of information out of Ruth. Ruth Crampton is from Avant, and she's very knowledgeable in this area. So welcome, Ruth, and thank you very much for being with us tonight.
Thanks, everyone. Thanks for having me. I'll just sort out my slides. Let me know if there's any problems with that, but hopefully you can see my presentation.
Yep.
So I'm here to talk to you today about challenging patient interactions. We're also going to talk about managing patient complaints. We'll talk a little bit about ending the doctor-patient relationship. And we'll focus on a couple of particular patient situations and also talk more generally. I'd also like to take the opportunity to acknowledge the traditional owners of the land I'm in. I'm in Ringwood tonight, so it's the Wurundjeri people, and Wurundjeri comes from the name of the gum tree by the Yarra River, and Juri is the grub that's found near that tree. So culturally accepted interpretation of that is the people that live near the Yarra River. So welcome, everyone. Thanks for having me. So we will be discussing just some general advice, as I said, looking at particular types of challenging patient interactions, complaints, and ending the doctor-patient relationship. Avant's done some research into reasons why patients complain, and it's a really interesting thing to try and explore. And one of the things that we found is that 1 in 8 claims had an element of the patient feeling disrespected by the doctor, and perceived disrespect or alleged disrespect. I'm not saying that that was necessarily the case, but that's the patient's perception. And the primary type of claim where this was an issue was when the patient was complaining that something they'd requested or something that they'd wanted, some expectation that they had, wasn't being met. There's also been some studies done. The British Medical Journal published a study that said 15% of clinical interactions with patients are perceived as difficult by the doctor. So that's just the two sides of that coin. So it's certainly an issue that's out there. I like this concept, which is by Stephen Covey, the late Stephen Covey. He wrote that book, 7 Habits of Highly Effective People. And he talks about the circle of influence, the circle of concern, and the circle of control. And basically, it's just being aware of what things in life you can impact and what things you just have to let go because it's out of your control. And taking control of what you can, but just letting it go if it's something that you can be concerned about, but you can't actually do that much about it. So an example of that would be, say you wanted to go to the shops, but it's raining. So you can't change the fact that it's raining. You can be concerned about the fact that it's raining, but you can't actually do much to change that. But there are things within this scenario that you can influence. So you can put a raincoat on, you can get an umbrella, you can go a different time of the day. You can control your attitude. So you can be happy that it's raining and splash around in the puddles on your way to the shop. So just being aware of what you can and what you can't change. His point, Stephen Covey's point, is that if we want to be proactive in a crisis, or we do want to be proactive in a crisis rather than reactive, and so we focus on the things that we can control in order to be proactive. In my friendship group, we often say circle of control, or circle of concern, if it's something that we can't help, like the way, I don't know, a child's behaving in the supermarket or something. So first step, general rules when you've got challenging situations with your patients. First steps is, the first thing is, of course, to recognize the issue. And it's very easy, I think, especially when we're busy or tired, to put all the blame of the situation on the patient. But it's being aware that the reasons for the patient's behavior may not be just that they're an unpleasant person or a particularly demanding person. There can be lots of reasons for their behaviour: past experience, expectations, worry for a child, worry for themselves if they've got a chronic illness or a terminal illness. It's also important to realise that the patient may have unspoken, unrealistic expectations that you're not meeting, but because they haven't said anything, you don't know what you're not meeting. And all these things can influence the interaction and make the patient a challenging one. It is important also to remember that an angry patient can have a valid concern. Just because they're difficult doesn't mean they don't have a reason. And so it's really important to remember to try that empathy and try and put yourself in their situation and try to get to the root of the problem and why it is that this behaviour is being exhibited. The next thing to think about is, of course, is it you? Is it you? We all have a bad day. We all have a headache. We, at times. The saying "halt," which is hungry, angry, late, or tired, is probably true to some degree of everyone at some point in the day. And so reacting inappropriately because you have no reserves, because you've had a busy day, because of something stressful that happened with the previous patient, or your previous interaction with a staff member. So it's really important just to reflect and just to acknowledge that sometimes the person that is equally at fault is yourself. Knowing your own limits. So being under stress and being close to burnout, especially in these last few years, everyone's been under a lot of stress. So taking a few minutes to calm yourself down, try and relax your body posture, and be aware if you're not going to respond effectively, or if this patient is really pushing your buttons, that you may need to step out of the situation and get someone else to take over, someone who's having a better day, and have a plan for situations where someone is in an interaction with a patient and they feel like they're getting out of control. Have a discussion in your practice about what the options are and what the solutions are in those circumstances. Sometimes the problem is the system, like, in a hospital environment, patients waiting for hours in the waiting room in emergency, in a GP practice waiting room, waiting for a doctor that's running late, but with no explanation. Once my husband and he was going to see a specialist, and we were both working from home, but we'd blocked out the time in our diaries to go. And we got a phone call to say, we're running early, a patient's cancelled, could you please come in an hour early? So we juggled everything. We said, yeah, no problem. We got there an hour early. We sat and waited there for an hour and 45 minutes and no one said a word to us. So by the time we got to the doctor, we were both grumpy. So all it takes is someone taking a moment to apologize for mucking you around. And it's very hard to be grumpy when someone's, made an effort to apologize. There can be a scenario such as a patient who becomes quite abusive because they were charged an out-of-pocket expense that they weren't expected for example. And that could be a system issue because their costs weren't explained to them correctly at the beginning. Their past experience may be that they were always bulk billed previously. There can be lots of reasons that can contribute to that. So just trying to find out the functionality of the system and what it might be that might be done better to try and preempt any of that sort of behaviour. Managing expectations, we notice this a lot at Avant in terms of the reasons why patients complain is this unspoken expectation or an expectation that isn't met. And it's important to realise that they can have an expectation without saying what that is. It's just like something that they expect you to understand or to appreciate. So it's really important to be clear and to set those boundaries and expectations with every meeting. So if a patient comes up to the front desk and the doctor's running late saying it's going to be 30 minutes so that everybody's clear when they sit down and wait how long they have to wait for. And if necessary, apologise. An apology goes a long way. As I said before, when we were in that situation, being kept waiting, apology would have really made a difference. So what to do if you come across a confronting situation, and again, a challenging situation. This is the general advice. So you need to first acknowledge that it's a difficult situation, that it's a challenging interaction, and really just name it. So, don't be scared of the elephant of the room, really verbalize what the difficulty is, and that helps build trust and openness with the patient, and it is the first step forward to trying to work through a solution. So support the patient by listening and carefully showing them empathy and respect, irrespective of how grumpy they are being. The one exclusion to that is of course your safety, but we'll come to that in a minute. People like to feel like they've been listened to, so be curious and try and get to the root of the problem. Try and find out what the actual problem is, and it's really human nature to try and win every argument. But in this situation, you're not trying to win, you're trying to understand. So don't argue back, don't talk over the patient, don't try and be right, don't interrupt. Within limits, let them have their say. And as I said, even a difficult patient can have a real problem and you don't need to win the argument. And really kindness can take the heat out of any argument. So just try and be, in the first instance, try and be as kind as you can. Try and acknowledge a partnership with the patient and let them know that, I'm trying to work towards a solution that can realistically assist you. Paraphrase what they've said, repeat it back to them, that active listening as they understand that the problem is, is that right? And then tell them what your expectations are. So set boundaries, this language, this behavior isn't acceptable. If you want me to help you, you're going to have to, tone it down, or you're going to have to stop yelling and, that type of thing. So let's focus on some of the particular kinds of patients. So we touched on it already, which is the aggressive and angry patient, which is really one of the most challenging experiences you can have in your day-to-day practice experiences. So this is the verbal, the physical, the confronting, the rude, threatening. It can be over the phone, it can be via email, but it's most scary when it's in person. And also the abusive person can threaten to harm themselves or harm others. So if you're trying to deal with this type of patient, it's important to use I statements and really emphasize the impact that this situation is having on you as the doctor or the staff member or the receptionist or whoever you are, and label the behavior, not the person, which helps to reduce the intensity of the situation. Advise the patients that you're aware that the behaviour is unacceptable. Every practice should have an acceptable behaviour policy, both for patients and staff. And so you can say to them, this behaviour isn't acceptable in this practice, and you're going to need to calm down, or you're going to have to ask you to leave. Be very firm. But at the same time, again, try to get to the root of the problem as best you can. Document really well what's happened. If it's on the phone or if it's a consultation, you can just end it and say, we're not getting anywhere here. We're going to end this for today. Call me back, or make another appointment if you want to keep seeing them. You can consider a kind of a patient style contract where if you want to come back, you're going to need to do X, Y, Z and get them to sign it. And at the worst case scenario, you can completely within your right to terminate the doctor-patient relationship or the practice-patient relationship. Safety first. So if you're in a situation where the patient is particularly aggressive or angry, you really need to keep note of yourself and your colleagues' safety. Safety is absolutely paramount. Now, practices should have safety discussions, safety plans, things put in place, and those things need to be well understood by all the staff in the building, and they need to be practiced, and you need to know what to respond if somebody engages in one of these safety procedures. So, for example, I've heard of a practice where a doctor was in a consultation that was really threatening, and they pressed the duress button, and there was an alarm in the reception area, but nobody knew what the alarm was for. Nobody knew what it meant, and everyone was going, oh, what's that noise? I haven't heard that before. So it was completely ineffective because it had never been practiced, and the education in the practice was really poor about how to respond. So it's not just having a plan, it's having a plan that everybody understands and can respond to. If you can imagine a scenario like a drug-seeking patient or a patient that's, demanding for some reason, and they're in a consultation room with Dr. Harris. Dr. Harris is an older female GP, quite small. The patient is a new male patient, tall, broad, not a patient she's met before, and he's asking for a script for fentanyl. Dr. Harris explains she can't write a script. Their policy is not to write a script for new patients. So the patient becomes verbally abusive, stands up. She's feeling quite threatened because the patient's towering over her, but she's on the wrong side of the desk. The consultation room door is shut. She asks the patient to leave, and he jumps around to her side of the desk and blocks her from opening the door. Just think about that in your practice, and what would the doctor do? Would there be a plan? Is there a duress button? Have you practiced what would happen in that situation? So it's just important to think these things through before they happen. Good communication skills, as aggressive and as unsettling as the situation may be, all patients deserve to be treated with dignity and respect. You haven't walked a mile in their shoes. You don't know what the bigger picture is. And so it's really important to keep that kindness, keep yourself safe, manage their expectations. Managing expectations in relation to this scenario with the drug seeker, it could be something as small as putting a sign in the waiting room that says practice policy is not to prescribe drugs of dependence, S8s to new patients, or the practice policy, if you're asking for narcotics, is to refer you to the local hospital or whatever that may be. So the patient comes to the consultation with that understanding and that expectations being made clear. Another group of patients, so we talked about managing expectations, and there's a group of everyone has expectations, but there's a group of expectations that are clearly unrealistic, and it's not something you can do. It's not something the practice can achieve. It's outside your comfort zone. So in terms of how you can manage that, the best thing to do is to be very clear with the patient about what you can and can't do to help them, and try to make a shared decision-making approach where you give them some of the, this is what I can do, this is what I can't do, these are your options, you can go here, you can, you can read this further information, you can go and seek a second opinion, or whatever the options are. But avoid being inappropriately neurotic. Being an inappropriate hero, so that you're trying to save the day, is what I'm trying to say, so that you don't go out of your way to do something for someone that's outside of your normal practice. So for example, I don't know, driving someone home on a rainy day, or lending money or doing something that that isn't normal practice and would only take you down a slippery slope of just loose boundaries. So being prepared to say no, being prepared for the patient to go elsewhere if you can't do what they're asking. So I know in terms of prescribing, there's a Ozempic, a drug that's for diabetes that helps with weight loss, and it's a really popular thing on TikTok. And we're getting a lot of doctors calling us saying that they've got patients really demanding this Ozempic for weight loss, but it's against the current TGA guidelines to prescribe it. Some doctors are comfortable to prescribe it, some doctors are not. There's a whole lot of diabetics that need the medication and there's a short supply. Because it's being prescribed to people wanting to lose weight. So this might be a situation where the patient has the expectation that they'll be prescribed it, but the practice has made a decision not to. And so, this is the sort of situation where you have to be prepared to say no. So clear boundaries, sticking within what you know and being prepared to say no are the key messages for the unrealistic expectations. Another group of patients is the non-compliant patient. So the patient who you give advice to and they don't follow it, you make appointments for and they don't attend them, really just cannot or will not, for whatever reason, comply with the medical advice. I mean, common things on this line are also things like weight loss and, altering exercise and, stopping smoking. Those kinds of things are really challenging to manage, of course, but the important thing in trying to manage this type of patient is the good relationship between the doctor and the patient is really grounded in trust. So, have a process in place for following up investigations and missed appointments, have the patient agree to things, really give them a good understanding throughout a consent discussion about the implications of not doing what you're advising them to do. Try and explore reasons for non-compliance, such as money or time, and document everything well in terms of what the practice has done, how many reminder phone calls have been made, how many follow-up emails have been made. Document that all well in their notes so that you're really trying to get the patient to take ownership of their own health needs. Another group of patients is the needy patient. So this is flattering staff, flattering the doctor, trying to bring gifts and trying to, manipulate, trying to get an appointment or get in to see the doctor ahead of time, being overly familiar, turning on the tears, that kind of behaviour can be really difficult to deal with. I think a clear delineation of the doctor-patient relationship is important here, and really just, again, having a practice policy about what is and what isn't acceptable in terms of gifts, and really reinforcing that, if one person is given a gift, say, oh, the staff will really appreciate this, I'll put it in the staff room, and, just deflecting it away from yourself personally. Taking control of things and really having a practice system where if this patient calls, making sure they don't get the doctor's mobile phone number, or or are encouraged not to use it unless it's an emergency, those types of reinforcing the behaviours. I did just want to talk a little bit about the racist patient or racist staff. Racism in general is really a topic that's getting a lot more airplay. We've certainly noticed it recently, a lot of requests for talks that deal with having difficult conversations, both with your colleagues, your peers, as well as with patients along the tone of racism. And the British Medical Association did a poll last year with 2,000 people responded, and 3/4 of them, or 76%, said they'd experienced racism in their workplace at least one occasion over the past 2 years. And so I think it's a really interesting thing to know how to deal with it and what to do about it if it happens to you or if you observe it. Excuse me for a sec. It's hard to know how to address it if it's a patient making comments or refusing to see a particular doctor for a certain reason. One thing I think that I believe is true about racism is that it's often quite unintended. So it's an unconscious bias. People don't intend to do it. to a greater extent. Of course, there's always exceptions to the rule. But it's really important to be aware of that kind of unconscious or implicit bias. And it's not always really obvious and out there. And it's not always, a bad joke or a really blatant comment. It can be really subtle things. So just being aware of it and how to manage it is a really important part of, being empathetic and culturally aware, culturally safe. So there's some important things to keep in mind. If a comment is made, you've got a choice whether to ignore it or to call it out. And I think, ignoring it is a choice. If you are a person of, First Nations person, or a person, from a different cultural background than others in the room, and there's a comment made, sometimes you've had a long day, you've had a rough day, you're tired, you just can't be bothered to deal with it. And that's fine. If doing nothing is your choice, then that's your call. You can't be responsible for fixing all the world's problems, every day. I think it's important, if you're going to speak up and if you're going to say something to address the comment, then it's a good idea to have things in your toolbox or things up your sleeve to say before the incident happens. So if it's something that you are aware of or something that you think might occur, then have a plan about how you're going to say what you're going to say when it does happen, so that you're prepared, so you don't have to think on the fly about what sort of response. If you choose that you don't want to speak up, but you want to address it, you can ask someone else to address the issue. And so that's about your colleague or your manager or somebody else and saying that I can't deal with this, but I think something needs to be said, and then asking someone else to address the issue. And again, have that person in your mind before the events so that you know who to turn to. The fourth option is to commence a formal process, because the behaviour is unacceptable, and you can start a formal complaint process if you choose. Our advice would always be to try and speak to the person directly first and try and resolve it, because, as I said, often it's an unintentional comment, and once the person is made aware of it, they are usually embarrassed and don't do it again. Now, this discussion is if the comments are made to you, but if you're a bystander and you overhear a comment, you also have equal responsibilities to either, speak up, address the issue directly, or the opportunity to do something more formal if you're a bystander or a witness. And sometimes if a person is experiencing a lot of racism, having somebody else step in and take over is a real relief, because it's tiring to constantly have to try and address poor behaviour. If the behaviour comes from a patient, that same British Medical Journal article came up with this flowchart about whether or not you as a healthcare worker can refuse to see a patient based on their comments. This particular flowchart actually is about if the patient is refusing to see the doctor because of their race. So I don't want to see that doctor because they are, Asian, Indian, whatever the discrimination is. And so you can have a look at this. I mean, it's a difficult thing to reason, but they're saying if the patient's unstable, really in an emergency, you have to treat the patient irrespective. If they're stable and they have capacity, then you can determine the motivation behind the request and then make a decision about it. There is an element in this flowchart that says if the reason for the request is clinically and ethically appropriate, you can accommodate the request and find them another doctor. So I was really struggling to think what would be clinically or ethically appropriate. And the only things I can really think of is people with historic prejudice based on past life experiences. So, if there was genocide or some kind of cultural discrimination, if the patient was Jewish and the doctor was German and they were from that generation that they were, alive at the time of the World War, then perhaps that's the sort of situation where you could say, okay, I can see their reasons behind it and we can step out and we can accommodate that. But generally speaking, of course, the option is to decide whether you want to negotiate or accommodate or transfer the patient's care to someone else. Other kinds of difficult, so we've covered some of the basics, but there's all sorts of other things that can make patients difficult. So around COVID, you know, as we all know, there's lots of challenges with regards to wearing a mask, being vaccinated, you know, not being allowed in the waiting room, that type of thing. We get a lot of phone calls about separated parents when the dad and the mum don't agree, and what to do with regards to, you know, an angry mum because the dad vaccinated the kid, and, you know, vice versa, those kinds of conversations. So there's all other sorts of things, and really the same rules apply. You know, try to get to the root of the problem, try and be kind, don't get in the middle of it, document well, you know, all that sort of thing. After the event, oh, Yvonne, have you got a question?
I do have a question. So in the event that the parents are bickering about a child that has been vaccinated, what do you do there?
Yeah, it's a really tricky one. We have got a good fact sheet. If you Google event separated parents, we've got a good fact sheet, and we've actually got a couple of podcasts on the issue. But basically, unless you are aware of a legal parenting order that restricts the authority of one parent or the other, then one parent's consent is all you need to act. So if one consenting parent asks for the vaccination, then you do nothing wrong to vaccinate, for using that as an example. But if you know the whole family and you do know that the mum is anti-vax and the dad isn't, you would be unwise to just plow ahead and vaccinate, even though you're not doing anything legally wrong. I would suggest that trying to get to the parent, getting the parents to sort it out is the best step. But if you're unaware of any issues and one single parent comes and asks for a child to be vaccinated, and you vaccinate them, then you haven't done anything wrong.
Yeah. Thank you. And could we maybe have the link to that resource after the session?
Sure, of course.
We've been asked a couple of times in the chat as well about links to the slides and what have you. So just a reminder to everybody that we will be sending out a recording of this session as well as slides in the next couple of days.
I have put together some links, but perhaps not the separated parent one, but I can certainly add it.
Right, thank you.
We get a lot of calls about separated parents.
Amazing, thank you.
No worries. So it's important to look after yourself. If you have a really confronting situation with a patient or a colleague, it can be really stressful, as we all know. So debriefing with a trusted friend or a trusted colleague. But the top tips are to reflect on your behaviour and think about how you might have done differently, because we always want to improve, to document really well, and to get the support you need. Like I said, debrief with a trusted friend. Top tips, I would say, be calm, be professional, try and see it from the patient's perspective if it's at all possible. Try and work together with the patient to find a solution, and consider doing some further training in how to manage, you know, these challenging kinds of interactions. The other thing I think is, and I've sort of mentioned it briefly, is to be prepared. So have things based on your past experience or on advice from others in your toolbox that you can pull out if you've got a patient that's really angry at the desk, or a patient that's really abrupt in the consultation. Say things like, how can I help you? What do you need? What do you need from me that I can realistically provide that's going to resolve this? You know, those kind of things. Another good one is, unfortunately, our practice policy is that, you know, we can't do that, whatever the thing is. So having those kinds of things in your toolkit so that you can wheel them out whenever you're needed, because there's nothing worse than fumbling and regretting afterwards that you wished you'd handled it a bit better. I'm going to move on now to patient complaints, because often the result of these types of interactions is that the patient does complain. So there's a few tips. One of the things I would say is this is my take-home message, make it as easy as possible for a patient to complain to you. Make it really, really easy. If anyone hints at wanting to make a complaint, go out of your way to give them the pen and paper to write it down. Make sure all the staff that interact with patients know what to do if the patient is unhappy and wanting to complain. Set up an email address that says complaints at murrayrivermedicalpractice.com, whatever, so that the patient feels like their complaint is being received from at a location that it's going to have some attention. There's nothing, you want to do everything you can to avoid the patient going into the car park, getting out their phone and leaving a bad Google review, or filling in an online form at AHPRA that then becomes a 2-year battle to try and resolve. You want to do everything you can to avoid that. So the way to do that is to make it very easy for them to complain to you directly, because then you're in control of how you manage that. I recommend having one person responsible for managing complaints, because then you have one person that can ensure that everything is followed up and fed back to the patient. You have one person who can see if there's any themes or any common things that you can learn from and improve your practice. Obviously, there needs to be a record or some kind of diary or location where complaints are stored and documented. There should be a policy or a process about what happens when the patient complains, so that it's very clear that even the smallest thing is given due attention. If you think it's a really significant complaint, you want it in writing, not verbally. And if you receive any sort of complaint, no matter how trivial, you should respond to the patient within 24 hours. And if within 24 hours you don't have an answer, you just respond to say, we've received it, we're looking into it, we're doing all that we can. I went out for dinner last night with a friend, and her mum is Italian speaking. And so she had a doctor's appointment, and her sister had to take time off work to take the mum to the doctor's appointment. So they got stuck in roadworks, and she said they got to the practice 4 minutes late. Now, who knows, but it certainly wasn't a long time late. And so they get to the practice and they are asked to wait. And 50 minutes later, Michelle had only taken an hour off work, but 50 minutes later, she went to the desk and she said, I'm just wondering how much longer. We've been waiting 50 minutes. And then the receptionist said, oh, we're not seeing you today because you were late. And so Michelle said, oh, can I speak to the practice manager? She tried to raise it and nothing. So then she emailed the practice, and a week later, she'd had no response. And so then she made an AHPRA complaint. So that practice could have done many things along that journey to prevent that complaint, which all seem obvious to us now. But what you don't want is the Michelle to write to AHPRA and then the practice has to respond formally. When patients complain, there's been a few studies about what they want to get out of it. And from the studies that I've read, I've sort of summarized it into the key points. They want to be heard and understood. They want to know that you've heard them and that they're upset and that you get that. Even if it seems trivial, they want you to say, okay, I'm sorry that happened to you. I've heard what you've said and I'm going to look into it. They want an explanation as to why that happened, or what's going to, or if there's any reason for it, or if there's anything that will make more sense to them. They want an apology. So you can apologize for the event without apologizing for your part in it. But what I mean is, I'm sorry that happened to you. I'm sorry that happened, but not I'm sorry that I did, X or Y. They want something to change. They want something to change as a result of what's happened to them. So whether it's a small thing or a big thing, they want something to change. So even if that something is, an apology, a notice in the waiting room to say, that what the privacy policy is if they think you've said some of their, private information at the front desk or something. So the things that you shouldn't do, is ignore the problem. It's never going to make it disappear. And if you don't get a response, the patient will just escalate. They're unlikely just to drop it. What you shouldn't do is accuse the patient of doing something wrong. Even if they have done something wrong, just don't accuse them of it. Just really keep your counsel quite tight and get all the facts. Don't tell the patient there's nothing you can do for them. If all you do is investigate it and come back to them with an apology, then that's something, but don't tell them there's nothing you can do. So when you're trying to resolve a complaint, you need to, depending on the scale of the complaint, of course, but assuming that it's a substantial complaint, you need to make sure that you've gathered the facts, that you have a good understanding of what went wrong, listen to everybody's, experience of it, and really just find out what happened on the day and make sure you fully understand it, what the complaint is about, who it is about, what the patient wants as a result of making the complaint. And if you need to, get a second opinion or give the patient further care or follow them up in some clinical way, make sure you do that as a priority. And then you need to respond to the patient. So whatever format that may be, generally, if it's a verbal complaint, you can respond verbally. If it's a written complaint, you should respond, written. But just make sure you get back to the patient and try and resolve it to the best of your ability. So that's patient complaints. And just the final thing I wanted to talk about was ending the doctor-patient relationship. Because we get a lot of questions about this, ending the doctor-patient relationship or ending the practice-patient relationship. Sometimes a doctor may want to end the relationship, but another doctor in the practice is happy to keep treating the patient. But if the practice decides that the patient is not welcome, then there needs to be a way that everybody in the practice knows that, because you don't want the patient being able to book an appointment online or book an appointment over the phone without it being flagged that they're no longer welcome at the practice for whatever reason. Technically, the legal response to ending the doctor-patient relationship is that any doctor is able to choose not to treat someone. The only exception to that is in an emergency, they're obliged to treat. And if they're in the middle of a particularly complex, treatment situation, they may want to resolve that before they pass the patient over, depending on the circumstances. But at any time, you can decline to treat a patient. There has been a bit in the media about this recently with regards to where does that fall in relation to discrimination. And you have to make sure that your reasons for terminating the relationship are not discriminatory because of the person's race, gender, sexual orientation, etc. And the way to resolve that is to make sure that your records as to why the patient is being terminated, as relationship is being terminated, is really clear. And that's an important part of the process. So when is it okay? So if any time when you feel like the trust has been undermined and you can't be objective and you can't, remove your negative feelings towards the patient or because of something they've done, if the patient's done some sort of prescription fraud, or they've been really aggressive and violent in the practice can decide not to see them anymore. So those kinds of things need to be considered, and you just say to the patient that it's in your best interest that I don't treat you anymore, and I'll I'm happy to provide your records to another doctor, and that type of thing. In the links that I'm providing, there's a fact sheet on ending the doctor-patient relationship that's got a template for a letter that you can use with different sort of scenarios that you can use. It's really important to plan well. So it may take some time. You may not be able to do it immediately. So it's important to think about what you're going to do, the reason why you're doing it, how you're going to communicate that to the patient. You may need to do it over more than one appointment. You may want to sound off with other people in the practice about the decision. You may want to get, if it's a doctor's decision, you may want to discuss it with a colleague. If it's a practice-related decision, you want to make sure that all the doctors in the practice are on board. Hey, Yvonne.
Hello. We do have a question. What happens if it's not the patient that you're having the issue with? It's, for example, like your friend taking her mother to the doctors. It's the relative they have the issue with.
Yeah, interesting question. I think I would discuss it with the patient and say, I'm not, your friend or whatever is not welcome in the practice because of their behaviour. You're still welcome to come, but if you want to continue to bring your friend to the practice with you, then you'll need to find another doctor. Yeah, it's a tricky one. I think you'll just have to be really clear about the reasons and then and document that well, because if the friend is behaving in such a bad way that you don't want them there, then you've got every reason to be safe at work.
Yeah. The other question was, at what point do you call the police?
Yeah, if you feel like you need their help, by all means call them. Yeah, absolutely. So, you know, there should be a practice policy in place about reasons why the police are called, and certainly safety of yourself and safety of the other patients is really important. And if you can't get the person out of the waiting room, then get everybody else out of the waiting room. But you know, you'll certainly need to get the backup of the police at certain, you know, if the situation gets really bad. There's been lots of examples of police being called, and even especially during COVID with patients arcing up because they're having to put a mask on and stuff. If you feel unsafe, you should call the police. It's better to be safe than sorry, right?
Right. Yeah, absolutely.
I have a low threshold.
Yes. Thank you. Thanks, Ruth.
Right. So we are just talking about the planning part of ending the relationship. So talking to colleagues and friends, making sure that everybody's on board, that the decision is made, you know, universally, and that sometimes what you might need to do is have a like, if you know the patient's coming in, have another staff member on rotation to be your backup, because you may feel like you need more support. Call your MDO. Of course, I should have said that first. We give lots of advice on this topic. So steps to the process. So the first thing is to discuss it with the patient and to really clarify the reasons why you're doing what you're doing, what your expectations are, and for what reason that the patient hasn't met the expectation, and be prepared to justify the decision with examples. Always put it in writing, prepare a letter, and make sure that the letter is really explicit as well. And if it's appropriate and if it's possible, facilitate alternative care. Make sure the patient gets a referral from you to another practitioner, and that their records and everything go with them. Provide those records to the new doctor, that type of thing. So finally, I would say do everything you can to encourage patients to give you their feedback directly. Every complaint is a learning opportunity. I know it's a cliche, but you really have to look at it that way, as feedback, not a complaint, and take that on board. Try and respond and change unacceptable behaviour and systems. Be kind to your patients if they're coming to you in a bad way, and try and educate and prepare your staff to deal with it. Look out for each other. And if you have a really challenging interaction with a patient, if you try to charge them an out of pocket, they'll probably only arc up, and usually the money isn't worth it. So consider just doing what you can to smooth the way to getting them out of the practice. So that's all I have for you. A little bit short on the time, but that leaves plenty of time for questions.
We actually don't have any more questions in the chat. No, but I suppose your last comment of, if they've been aggressive and then you don't charge them that out of pocket, that could work to their advantage, couldn't it?
Yeah, that could, but what's more important? Your staff's well-being, probably.
Yeah.
So yeah, and then I mean, it's the call you have to make, but I think that certainly our advice often is, if there's an unhappy patient, especially if they've had like some kind of procedure with a big out of pocket, either delay the charge until you've resolved the issue, or consider how much the charge is and how much it's worth to you just to settle it. Yeah.
We do have a comment from Suzette. How does trauma and grief fit in?
So if the patient's grief-stricken and behaving badly, so I think I mean, that's a really good point, and people behave really unusually for their personalities at times of real high stress and grief. And so if you were, you know, being kind, trying to get to the root of the problem, you're aware of what the issue is, even if the behavior is unacceptable and you're still setting boundaries, but I would probably give them quite a long leash to you know, to work through their issues. You know, you have to keep your own safety in mind. You have to keep the safety of the practice in mind, and so you'd have to make that decision on a case-by-case basis, I guess.
I suppose, you know, knowing your patient and their personality, you might be a bit more lenient if you know that it's quite out of character for them.
And I think that's true, Yvonne. If you know the patient well, you can make a different decision perhaps than if it's a stranger that's just come up to the desk. Yeah.
Thank you very much for that question, Suzette. And anybody else got any questions? We've got Ruth here, so let's throw something curly at her. Okay, I've got one. What resources are available for staff that need to consider their customer service, thinking of those that don't realise they are being abrupt or rude to patients?
Yeah, it's a really good point, isn't it? I know I don't have any resources at Avant along this line. I will say that in terms of the process for confronting a staff member with behaviour that you might think needs to be modified or changed, the best way to do that is what we call a coffee conversation, or like a casual conversation. I quite like to do it going for a walk, because if you ask the staff member to go for a walk, you're walking side by side, so you're not looking each other in the eye, and it's not so confrontational, and you can say, you know, there's something I really wanted to talk to you about, work related, but I wondered if we could go for a walk around the block or around the park to do it. And then you can have the casual conversation with them. And this is an approach that's used to address bullying, and it's also recommended to address the things that we were talking about with racism and comments like that. So you say to the person, I noticed that you are, you know, abrupt, and whatever the issue is. And the person may be, oh my goodness, I never realized, and, you know, try and work with them to do something about it. Often when confronted, the person who's confronted with that in that kind of casual, informal way will amend their behavior. And it's only something like 15% of people that won't. One thing that was said to me once was, I was a nurse educator in the operating room, and one of my friends said to me, I thought I was no nonsense, you know, firm but fair. That's what I thought. My friend said, you come across much harsher than you intend. And I was like, oh, really? And I really worked on it. Like, I tried to be much kinder and to say things in a much more gentle way, as opposed to the direct to the point way that I used to say it. And I asked around a couple of years later to a new group of students, and I said, does anyone feel free to tell me if you think my behaviour or comments are ever harsh? They go, oh God, no, you're the kindest, you know, you're the nicest, you know. So I'd like to think I did really change my behaviour. So that's an example. But I think in terms of customer service skills, it's a really interesting one, but it's just that kind of customer's always right, don't try to win it, you know, like all those kind of comments. I know, sorry, just one other anecdote is that my sister owns a shop back in New Zealand, and I sold somebody a clock that my brother-in-law's a designer, and he makes the things they sell. So that's all very personal, you know, things like art, you know. And I sold this guy a clock for his girlfriend, and she returned it, and she didn't like it. And my sister was a bit affronted that she'd returned it, and she was a bit snappy, a bit rude to her. I was there both times. I was there when the lovely boyfriend bought the clock, and I was there when the horrible girlfriend returned it. And I went out for dinner about 3 years later, and there was a couple there, and they said, we know somebody who bought a clock at that shop once, and she returned it, and the staff member was so rude to her. And so it just shows you that 3 years later, in 20 years, 2 clocks have ever been returned, and that was one of them. And, you know, and 3 years later, people are still talking about it at dinner parties.
Yeah,
you know?
yeah.
So you're just got to be really careful about your business reputation and really act on those staff members that you think need more mentoring and more coaching, because it is your business and your reputation, and you don't want those bad Google reviews that the receptionist was rude and didn't apologize when we were kept waiting for 50 minutes, and, you know.
I remember when I first started as a receptionist many moons ago, I was always told to smile before I picked up the phone.
Yeah.
And when you smile, and that comes through when you're actually answering it. So I always still use the same sort of concept. Doesn't matter what's happening around me. I always try and smile. And so, yeah, a little bit difficult. Are there any resources or anything that you could, or training sessions that you've heard of?
Yeah, I don't know of any, sorry. But we've got risk advisors who are really up on all this stuff. And so I'll ask around, and if I hear of something, I will forward it through.
Perfect. And I'll do the same with our education team. I do have another question from Suzette, and there's a couple points to it. So, to what extent is the patient's mental illness taken into consideration in such scenarios, e.g. those diagnosed with BPD or a personality disorder where the patient has problems in self-regulation? If the patient's not complained about you if the patient complained about you completely wrong, something you didn't do at all, and patient has gone all gaga about it, how are you supposed to react? I had one lady who didn't like me racial, and she would make up so many complaints about me.
Yeah, very challenging. I think the mental illness and the bad behavior thing is a really challenging way to address it. I think the practice needs to have some processes in place. So like that patient always sees the same doctor. They are, there's an agreement between the patient and the practice about the way they'll behave, that type of thing, that the boundaries are kept quite tight. In terms of the complaints to the practice, I guess you'd have to make it on an individual understanding as to how much was enough. You would need to make sure that the staff that were involved in those complaints were really well supported, and that the practice went out of their way to support their staff in terms of the constant inappropriate or inaccurate complaints. That's my thoughts about that one. But I would, like, if there was a particular patient that was a particular scenario, I think the practice needs a particular plan to address all those particular issues. You know what I mean? So something really bespoke I'm not the best at mental health issues, but there's usually some kind of treatment plan or agreement between the practitioner and the patient. So making sure they really adhere to that.
Thank you. I have to admit, I've been to a practice once, and this GP is just amazing. She has a lot of difficult patients that come to see her. And there was one particular patient who has been quite disruptive in the waiting room, and they knew that patient would be like that. So they always had a spare room where this patient was directed to go and sit in.
Yeah, perfect.
So everybody else in the practice and in the waiting room weren't feeling uncomfortable. This patient came in with a carer, so they both went into a room, and that's where they sat until the GP was ready to see them. So there's different strategies, I suppose, when you get to know the patient, and when they come in, you're ready for them.
Don't keep them waiting. Give them the next available opportunity to see the doctor, get them in, get them out. Yeah. Exactly.
I have another one here. With COVID screens and masks, it seems both patient staff are yelling to be heard, and sometimes this is personal information. How can we mediate this issue?
Yeah, it's a really difficult one, isn't it? You have to be very wary at the front desk about what is and what isn't said. We've even had situations, we've heard of situations where you've come out and you've said Ruth Crampton, and there was a younger, teenager or whatever, and a guy in the practice heard her name being called out and then tracked her down because he thought she looked a bit of all right. And so you have to be really careful of all that sort of thing. So I think I'm a big advocate for using your driver's license, getting the patient to hand over their driver's license so that you can get all their personal information without having to speak. And I guess in this day and age, you then need to wipe it down before you give it back to them, which is annoying. But, or if you think a patient is particularly hard of hearing and is yelling, or you're having to yell to be understood, go to a different room. If it's personal, if you think the information is personal, find a side room where you can have the proper conversation with them, rather than doing it in the reception area.
Amazing. Thank you. And I think that's it. I don't think I've missed anybody. Done that one. So keep them coming if anybody has any other answers. Please, any other questions, please let me know. But I think that's about all at the moment. I can't think of any. Oh, hold on, here we go. How many doctors need to do a course in self-protection, self-defense type things?
Everybody. Really. That's what I'd say everybody does. I mean, you need to have processes in place, like the duress alarm, like a process in place for what to do if you're the last person in the practice and you've got to go to your car, light, external lights, and, all those kinds of things. Everybody needs to be aware of that stuff. But in terms of, like self-defense training, or if you're in a practice where you think that's a particular problem because of the area, the area you're servicing, or, for any other reasons, I think everybody should learn techniques to de-escalate and to defend, themselves and their colleagues.
And I suppose when you think of most practice rooms I've been in, to see a GP, the patient usually is sitting at the door.
Yeah.
And the GP is inside, so they could easily be trapped. So those
so moving
processes.
your rooms around so that you've got easier access to the door than the patient. Yeah.
And knowing when the alarm goes off, what that means.
Yeah, exactly.
Is very important.
Exactly. Practice all your little, routines. Yeah.
Yeah. Fire drills and, panic button drills, and what else you need to do. What about patients that, and I suppose that's something we, if you've had some kind of threat over the phone. So if someone's called and said, I don't know, dare we say the bomb word, or, there's, what resources can practices use for that?
So there should be some kind of card or emergency thing by all the phones to say what to do if you get a phone call that's a threat like that. And, I'm just trying to remember back from my days of working in a practice, but it was along the lines of signaling to someone else to call the police for you to keep the person on the phone. There was all these kind of things that you needed to do. Get a pen and paper and take notes of anything you could think of, like the accent, the background noise, all of that sort of stuff. Take every threat seriously. Don't just dismiss it. And then escalate it as appropriate.
Yeah, I think that's about our drill at work as well when we're on reception. But again, that's sort of making sure everybody does their training at least annually, if not 6 months, just to refresh the processes.
Yeah, for sure.
We have a lot of thank yous and appreciate valuable insight. So we've got a lot of thank yous in the chat. So
there's about 100 fact sheets on the event website that are free for everyone to find. So it's called the Event Learning Centre, and it's my job to keep that place up and running and current. So if you ever got a question, or there's one on safety, there's one on ending the relationship, there's one on separated parents, there's one on managing expectations, there's heaps of them. So it's a good place to go if you've ever got a question like this.
Right. Just to remember everybody that we'll have a link coming out in an email with all that information in it. So, give Ruth feedback. If you find something that's out of date or you need something extra, feedback will...
let me know.
Yeah.
Thanks, everyone.
Yep, I think that's it. Thank you. At 7:34, we'll give you about 26 minutes back to the evening.
You're welcome.
But thank you so much, Ruth. Thank you for your time. And thank you to Selena in the background that's been keeping us on our toes, making sure the session runs smoothly. Selena has popped in a survey into the chat, so if everyone could just take their time to complete that survey before leaving. But we will probably send you another survey in the next couple of days as well to complete. Just let us know what you thought of the session, if there were any other topics that come up or any other questions that come up once we finish tonight. So thank you so much, Ruth. Thank you, Selena. Thank you, everybody, for joining us. Good evening. Bye.